Hello and welcome to another intensive care hotline and intensive care at home emergency Q&A for families in intensive care and with intensive care at home. My name is Patrick Hutzel. I am your host of the show. We'll be going for approximately an hour. Please ask any questions you would like here. If you have a family member in intensive care, or if you have a family member that needs intensive care at home, or maybe you yourself need intensive care at home, please ask any questions you would like here. You can type them into the chat pad, or you can connect live with me here on the StreamYard link, and you can talk to me directly here. Now, also, if you support the work that I'm doing here and that we are doing in the background, I encourage you to subscribe to my YouTube channel, click the like button, click the notification bell, and share your comments far and wide, and obviously share the video with your friends and family so we can help as many families in intensive care as possible. Now, what makes me qualified to host a show where I can ask emergency questions or answer emergency questions for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and where I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can confidently say that we have saved many lives with our consulting and advocacy. And you can verify that on our testimonial section at intensivecarehotline.com. And you can also verify it at our intensivecarehotline.com podcast section, where we've done client interviews. I'm also the founder and director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, and we are providing a genuine alternative for a long-term stay in intensive care, once again predominantly for long-term ventilated adults and children with tracheostomy, but also for adults and children that need home BiPAP, home CPAP, home tracheostomy care without ventilation, home TPN, home IV potassium infusion, home IV magnesium infusions, home IV antibiotics. We also provide central line, PICC line, Hickman's line, as well as port management at home. We also do ventilation weaning. We also do palliative care at home. We're also sending our critical care nurses into the home to provide an emergency department bypass service, and where we, provide emergency care at home to avoid emergency department presentations. And we have done so successfully for the Western Sydney local area health district as part of their InTouch program. We're saving around 5,000. We are saving around 50% of the intensive care bed, and we're saving around $2,000 per emergency department admission. Again, it's a win-win situation. Okay, without further ado, let's get into today's question. I also want to welcome our viewers on replay. I know we always get a lot of viewers watching this show on replay. I want to start with the first question. If you have a question, I encourage you to type your question into the chat pad, or connect with me live on the StreamYard link here, and you can talk to me directly. You don't have to go on camera. I won't bite. I'm here to answer your question or your questions. So connect with me directly here. If not, I will read out the first question and answer the first question. So the first question that I have is, it's a fair bit of an email, but we are here. I'm here to answer questions in detail. It's all about the depth of the questions that are being answered. So this is someone who has their family member in intensive care. So my sister sat in the cardiac chair about 1 to 1.5 hours today. The nurse was unable to continue staying with her, so she was returned to bed. They can't leave her alone, even though she's strapped in the chair, because she wiggles down the chair until she's almost falling out. She's still on 3 medications to control her blood pressure: hydralazine, metoprolol, and one other. Her lungs are improving. The doctor told me they don't have the resources at that hospital to provide physical therapy to my sister other than a cardiac chair. They said their purpose is only to treat acute illness. Today, she was breathing, using a tracheostomy collar and only on humidity. Not at all agitated, and she was doing quite well. They elected to stop after 6.5 hours. The guy from pulmonology asked me not to mention him to doctors, but told me he thinks she's very close to being completely weaned off the ventilator. She was doing so well on the tracheostomy collar. So she was on flow and doing all the work herself. He said maybe as soon as 3 days. He said possible to try a speaking valve soon. Now I need to stop. The email continues, but I need to stop here for a moment because I need to shed some light on the context here. This is a client we've been working with for quite a few weeks now. When the client first came to us, they felt coerced by the intensive care team to stop treatment. The intensive care team was telling the family, well, your family member will not have any quality of life. They will not survive. And if they do survive, they won't have any quality of life. Well, whilst we don't have a crystal ball, we never have a crystal ball. Here's what I do know after having worked in intensive care nursing for 25 years. Approximately 90% of intensive care patients survive. That's 90%, 90. That means the odds are in your family member's favor to survive intensive care. So the whole doom and gloom and negativity from intensive care team that they apply to almost every patient in ICU is not worth their time and their effort, because most patients survive intensive care. So unless you're doing your own research, you'll be fighting an uphill battle right from the start. In this situation, we advise the family to not give up, unless they had an inclination that, their family member didn't want to survive. Some people, they say, look, if I go into intensive care, that's it, I want to die, But that wasn't the case. So we advised the family to keep pushing for treatment. It's their choice. It's not the intensive care team's choice. And they did. And after some ups and downs, it wasn't a straight line. Here we go. Weeks later, their sister is sitting in a cardiac chair, and she's getting closer and closer to being weaned off the ventilator. That is fantastic news. That is fantastic news. Think about it. If you agree to hospice or to end-of-life care, you know the outcome. The outcome will be end of life. If you continue and you give your family member a chance, you don't know the outcome. But you've certainly tried. You've certainly tried. The other thing that you always need to keep in mind is there's plenty of time to talk about end of life. Plenty of time. I've made a video a few weeks ago with the title, something along the lines of, what's the hurry to kill a patient in intensive care? And if you as a family member are faced with a situation where intensive care teams tell you, well, you should move your family member to hospice, you should let them die, we should apply palliative care because they won't survive, and even if they do survive, they won't have any quote unquote quality of life. Well, what's the hurry in killing your family member? What's the hurry? Where's the rush in killing someone? Think about that. So let's continue with the email. So they're controlling the blood pressure only on the medications that she's also taking at home. She pulled her feeding tube out of the nose earlier in the day. 2 of the doctors were in and I didn't hear the end of it. I was told she was at risk of aspirating and they had to order a portable x-ray to make sure it was placed in the right position. They made a very big deal about it. Even the nurse was chastising me for not allowing the PEC surgery. He wasn't able to give her the medications until it was back in. Yeah, it does happen that patients in intensive care pull out the nasogastric tube. It does happen, right? And then you put it back in. and we still advise against the PEG tube. I've made countless videos why we are advising against the PEG tube. I'm not going into that on this occasion because I've made countless videos about that. Do not give consent to a PEG tube. A nasogastric tube will do fine. There are very few exceptions when you need a PEG tube. The majority of patients in intensive care are perfectly fine with a nasogastric tube. So the email continues. They changed the medications for staph pneumonia to cefazolin as they got the culture back. She had been on broad-spectrum antibiotics to begin with, but now she's on cefazolin. Her white cell count was back up over 14,000. Just as a side note, white cell count is usually, a normal white cell count is between 4 to 11,000. Hematocrit in the past 3 days was, hemoglobin in the past 3 days was 10.7, 9.3, 8.7. Hematocrit was 34, 29, 27. I asked why they weren't bringing in infectious disease for a consultation, and I was told basically it wasn't necessary. They had her under control. The recent echocardiogram revealed good globally left ventricular ejection fraction, now 62%, up from 49%. The right ventricular ejection fraction is normal. She has mild regurgitation of mitral and tricuspid valves. No murmur heard with the stethoscope. No pericardial effusion. No concern with the heart. Right. So that is really good because, you know, this particular patient had a cardiac arrest / heart attack when she first came to ICU, and her ejection fraction initially was very poor. So what is ejection fraction? Ejection fraction refers to the contractility or the pump function of the heart. Okay, the pump function is weak or poor, you know, that means there's not enough blood pressure, right? Blood pressure is usually low, which means organs are not perfused enough, right? So, well, that's a good sign. And again, this is on the background of the intensive care team telling the family their family member won't survive, right? So all the doom and gloom was not necessary. And one should question then the clinical judgment of intensive care teams. One should absolutely question the clinical judgment of intensive care teams. It's very poor. It's very poor, you know. The email continues. They did take her catheter out, so that should help with preventing a UTI. UTI stands for urinary tract infection. A lot of patients in hospitals that have an indwelling catheter are at risk of contracting a UTI, a urinary tract infection. The email continues. Now my sister was happy and engaged. Her eyes were wide open, and she was smiling non-stop for a couple of hours. She nodded her head yes several times when asked questions. She was not yet shaking her head properly for a no. She looked remarkably well and happy today. She seemed very aware of our conversations with her and seemed to be comprehending well. She was able to move her hand up to pull out the tracheostomy, so must be working to a certain degree. Well, she also pulled out a nasogastric tube, so it definitely must be working to a certain degree. She smiled when we kidded her. She was not kicking all over the place as usual. She was much more relaxed. The pulmonary guy said he thought it was because she had over 6 hours off the ventilator. After they put her back on the ventilator, she stopped being engaged and smiling and appeared to want to rest. Yeah, and I briefly stopped there as well. You know, when someone is being weaned off the ventilator after weeks of on the ventilator, after weeks of being in an induced coma, you have to expect a sort of 2-step forward, 1-step back approach, right? It can take time weaning someone off the ventilator, which is also why it's so important that if you have a family member critically ill in intensive care, you need to get them weaned off the ventilator in the first place. So to illustrate this more in more detail. So just this morning, I've been already talking to a number of inquiries, and the scenario is always the same, or seems to be always the same. Family member goes in intensive care with a pneumonia or cardiac arrest. They end up intubated, end up, on a breathing tube in an induced coma. And then after about a week or so, intensive care teams tell the families, well, your family member is very unlikely to survive. And if they do survive, they will have a very poor quality of life. We should move your family member to hospice, or the alternative is to do a tracheostomy, right, and continue keeping them alive, but there will be a very uncertain outcome. And we believe their quality of life will be very poor, right? And this is very similar to the email that I'm reading out at the moment. Here's probably the most important question you need to ask right from the get-go. They're giving you a very black and white approach in terms of, you should be either agreeing to hospice and end of life, or you should be doing a tracheostomy. That's a very black and white approach. It's either live or die. And if you live with a tracheostomy, the outcome is going to be poor anyway. Almost like managing your expectations, creating a negative narrative, right? And also trying to stay in control of the narrative, right? But it is so important that you create your own narrative. And you can only really do that with research. And, if you have someone on your team like myself that can handhold you through the process and that can give you guidance all the way, gives you guidance all the steps along the way. Because I've seen it hundreds of times, thousands of times. I can predict what's going to come. Right? I can predict clinically often what's going to come, and I can also predict the behavior of intensive care teams. So, but with this black and white approach of either saying, well, your family member should go to hospice and die, or B, should have a tracheostomy, and if they do survive with the tracheostomy, quality of life will be poor and they will never be able to come off the ventilator, right? Which is what they're telling this family here, where I'm reading out the email, and now she's weaning off the ventilator. Once again, you have to question their clinical judgment, right? But listen carefully now. The most important question that you need to ask when you get given this black and white approach, either hospice or tracheostomy, you need to ask the most important question here. Well, what can we do to avoid the tracheostomy and wean your family member off the ventilator and the breathing tube and avoid the tracheostomy in the first place? That is the most important question that you can ask. And they're not even mentioning that because they're trying to wash their hands clean. Right? So you have to know what are the right questions to ask. Very, very important. If you don't know what questions to ask, you'll be lost. Okay, so let's carry on with the email. Hasn't finished. It's a long email, like I said. My sister is still on 2 seizure medications: Depocaine, valproic acid, and Keppra. One of the doctors left a message on my phone. They're planning for a discharge soon. The doctor made a point of saying she has to go to a certain facility in downtown, and I'm not going to mention the location now. So the doctor made a point of saying she has to go to a certain facility in downtown because I won't do a PIC. I told her long before I said no to the PIC. I was told that was the only hospital she could go to anyway. If there were other LTACs in this location she could go to, I would certainly like to know. The doctors are constantly trying to create an argument to let them do a PIC. I would like to know if they're able to wean her off the ventilator and she's able to be in an LTAC closer to home. Are we still opposed to the PIC altogether? I'm still working on getting the discharge rules. yes, I am still very opposed to the PEG, especially now that she's coming closer of getting off the ventilator, right? I've made countless of videos over the years why I'm not recommending a PEG. The only time I would support a PEG is for patients that are showing not to come off the ventilator ever, right? If a patient can't come off the ventilator for whatever reason, then a PEG is inevitable. PEG is inevitable, right? But now that your sister is showing signs to get off the ventilator, no need for a PEG tube. Absolutely no need for a PEG tube whatsoever. So then, and also there's research out there why a PEG tube is causing more harm than a nasogastric tube. And just as a side note, I think I do need to mention that here, is when someone ends up with a PEG tube instead of keeping a nasogastric tube in place, in healthcare, I've been repeating myself there for years, but I think I can't probably say it often enough for people to really understand. When someone is having a PEG tube, it has the perception of permanency, which means people look at a patient in hospitals or in nursing homes with a PEG tube and they go like, oh yeah, this person will never eat and drink again, right? You don't want your family member to be looked at that the PEG tube is permanently and that they will never eat and drink again. You don't want that. Absolutely not. Whereas a nasogastric tube has the perception of it's temporary. And people will need to make an effort to wean someone off a ventilator. They need to make an effort to get people to talk again, get people to eat and drink again. Right? So very important that you know the difference, and very important that you look at it for what it is and you look at it with open eyes and you make the right decisions here. So the email continues. It has gotten unbearable to visit my sister. These doctors are relentless. I finally just turned my back on them yesterday and told them I need to visit my sister. Yeah, I can see that they can be relentless. Just ignore them. Take it as a compliment that they are relentless because they know you've got insider knowledge that other families don't have, right? And that's why they're being relentless. So take it as a compliment. Just ignore them, you know. Then the email continues. I spoke to the medical records director about getting all her records on a daily basis, and they can accommodate me except on the weekends as no staff is available. I will forward them to you so you can look at them. The format they send them in is very awkward. It takes me a while to get them organized. Okay, well, once again, you have the right to access medical records. I wouldn't play their game. Just keep demanding what you're looking for, right? Keep demanding what you want. And it is your right to access medical records. It is their duty to give you access to the medical records. Very, very simple, right? Don't play by their rules. You can make your own rules, right? You can make your own rules. But the takeaway from this email really is that, you know, don't buy into the doom and gloom. Know that approximately 90% of patients in intensive care survive, right? And that's pretty much all you need to know to come to your own conclusions. You don't need anyone belittling you about your decisions. You know what decisions you can make, right? You know full well what decisions you can make. You know full well what rights you have. And don't let anyone bully you into something that you don't want, into something that you know isn't right. Okay? So you can think for yourself. Always think for yourself. And don't let others make decisions for you. Right? You're an adult and you can make decisions for yourself. Now, so that concludes this email. Now, do you have any questions from your end? And if you do have any questions, either type your questions into the chat pad or use the StreamYard link that's in the comment section here, and you can connect with me directly and you can talk to me directly. I can see we've got quite a few people here, which is great. You know, now is your time to ask questions. Now, here's another situation that I was dealing with, excuse me, this morning that I need to shed some light on. So again, another client is in ICU at the moment. They went into ICU with shortness of breath, respiratory failure, and they ended up being intubated. Now, this is a client that's been in and out of ICU for quite some time. We've been working with the client for, I think, for over 12 months now, possibly up to 18 months. You know, every time they're going into ICU, they're reaching out to us, they get the second opinion, they look at medical records, you know, and so far we've always helped them to get out of ICU again, get out of ICU alive, of course, right? The situation is that once the patient got intubated, you know, they then ended up with a meningitis that they could diagnose with a lumbar puncture. And patient is also now in kidney failure, probably needs dialysis and or hemofiltration to manage the dialysis and hemofiltration. Interestingly enough, as part of the meningitis, she also now has seizures. This patient never had seizures before. She's now on anti-seizure medication. She's not on sedation or opiates at all, so she is tube tolerant, i.e. she's intubated. You know, normally patients are in need use coma, but unfortunately, the the meningitis and the anti-seizure medications are keeping her drowsy, and she's not waking up yet, which is obviously a concern, right? So they are giving her antibiotics for the meningitis, right? And hopefully, once that's cleared up, she can wake up, the seizures will stop, you know, and then the anti-seizure medication can be lowered. The question here now is, what's keeping her drowsy? Is it the meningitis? Is it the anti-seizure medications? Because anti-seizure medications, especially in high doses, also have a sedative effect, right? Now, the next challenge that this client is facing is that they're in septic shock. So, you know, with septic shock, they are on high doses of inotropes and vasopressors such as levophed, vasopressin, norepinephrine, and the likes, right? And that is considered high doses of life support. So, you know, this lady is now on ventilation support. She's on high doses of inotropes and vasopressors. She's got a septic shock. She's now going into kidney failure. So there are quite a few things that are not working in her favor, right? And the family member that's the next of kin and the decision maker, you know, is now having second thoughts. You know, should I continue treating? Should I not continue? Should I, you know, should I potentially issue a DNR? You know, and these are all relevant questions. And I think there's a difference. If those questions are coming from a family member, that's a very different approach to, in comparison, if it comes from the intensive care team, who, you know, has usually one agenda and one agenda only, which is, you know, to get the patient out of intensive care as possible, death or alive, unfortunately, right? So this particular client is also, you know, on up to 70% of oxygen on, you know, FiO2 on the ventilator. And she's not really making any progress at the moment. And, you know, she's also fluid overloaded on the chest because of, once again, of the kidney failure. You know, certainly a very sick patient here. So what are the next steps? Well, the next steps are she most likely will need to go on dialysis or hemofiltration because simply they've given her Lasix and furosemide to try and increase urine output, you know, with Lasix or furosemide, but simply couldn't get a result, couldn't get her to make more urine, and therefore therefore, she needs dialysis and hemofiltration to keep her alive for now. Certainly a very tricky situation. And if you are or other family members are confronted with a situation like that, you need advice. You need to understand what's going on clinically, right? That's why it's one of the many reasons you need a second opinion, right? You need to understand what's going on clinically, right? And you need to understand, are they doing all the right things, right? If they're not doing all the right things, then you can and you should question and challenge, right? And again, always keep in mind, approximately 90% of intensive care patients survive. So why would your family member not survive if the odds are in your favor? Another very important question you need to ask in situations like that is your family member in a real or in a perceived end-of-life situation? So what do I mean by that? A real end-of-life situation is a situation where no treatment, no medications, no surgery, no equipment, no staffing levels that you could increase will save your family member's life. Let me repeat that. A real end-of-life situation in intensive care is that no treatment, no surgery, no medications, no fancy equipment, no nothing will save your loved one's life. That's a real end-of-life situation. Most families in intensive care deal with a perceived end-of-life situation. That's getting sold to them from intensive care teams as a real end-of-life situation. But nothing could be further from the truth. Perceived end-of-life situation is there a perception that your loved one is not going to survive here? Well, on what basis? Right? On what basis would your family member not survive intensive care? Good question to ask. Right? Again, the research shows approximately 90% of intensive care patients survive. So why would your family member not survive? Chances are the intensive care team perceives an end-of-life situation, but it's not real. But it's up to you to make that distinction. And we are providing you with all the tools here at intensivecarehotline.com to make that distinction. Okay, to provide that distinction. Okay, so more and more often we get inquiries from families, like I said, but I think it is so important that you understand. More and more we're getting inquiries from families in intensive care where they get told, we have two options here. It's either end of life, because that's quote unquote in your family member's quote unquote best interest. Again, I've yet to find out why it's in someone's best interest to die, especially with the odds in their favor. I've yet to find out what the rationale behind that is, right? Or B, they should have a tracheostomy to prolong life. Once again, that is a very black and white approach. I don't like it. The third option here that you need to ask for and push for from day one is, how can we wean my loved one off the ventilator and the breathing tube? That's assuming, obviously, your family member is in intensive care with the breathing tube intubated. There's patients in ICU that are not intubated, right? But the reality also is those patients are probably, the family members of those patients are not probably looking at us because, they're not as sick as most of the families that we are dealing with. Okay, so I have written an article, How to Wean a Critically Ill Patient Off the Ventilator and the Breathing Tube. And I encourage you to look at that article and video, because that needs to be part of your toolbox when you have a loved one in intensive care. You need to understand that the black and white and doom and gloom approach from intensive care teams saying, well, the best option here is hospice or a tracheostomy. And if your loved one has a tracheostomy, they won't have a good quality of life. They most likely won't be weaning off the ventilator, rah, rah, rah. Once again, that's a very black and white approach. The third option that you need to push for from day one is to get your loved one off the ventilator as quickly as possible. Right? So critically important that you push for that. It's possible. Absolutely possible. Right? Once again, most families in intensive care simply don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. That is exactly what everyone you watching this is dealing with. Right? And if you are flying blind when you have a family member in intensive care, you will just do that. You will be flying blind. But that's not a good situation to be in. If you are flying blind when you have a family member in intensive care, that's dangerous. Simply dangerous. Okay. So, if you have any, before I move on to the next question, if you have any questions, type them into the chat pad or click on the StreamYard link here to talk to me directly so I can answer your questions. If there are no questions and you're just listening in, then I will read out the next question from Christy. Christy writes in, "Hi Patrick. My dad is in ICU for pneumonia and kidney failure. He's been given two options. Number one, to die naturally. Number two, get a tracheostomy, go to the rehab center with no guarantee of coming off. How can I advocate for my dad? We tour the rehab facility and it's depressing. Please advise." I had not really prepared for today, besides the first two emails. So this is exactly what I've been talking about for the last 40 minutes. This is what people present us with, right? This is very similar to the other two situations that I've explained in much depth today, right? Again, I read out the email so you can, digest that this is what people come to us with. So Christy says, "Hi Patrick, my dad is in the ICU for pneumonia and kidney failure. He's been given two options. Number one, to die naturally. Number two, get a tracheostomy, go to the rehab center with no guarantee of coming off the ventilator. How can I advocate for my dad? We tour the rehab center and it's depressing. Please advise." What have I been saying? Right. Number one, 90% of intensive care patients survive. So what is all the doom and gloom about here? Right. Number two, get a tracheostomy, get to the rehab center with no guarantee to come off the ventilator. Obviously, this is a client in the US, right? The intensive care team doesn't want you to know that there's a third option, which is avoid the tracheostomy, avoid end of life, wean your family member off the ventilator, and get them extubated, get them back to a normality as much as possible, and avoid tracheostomy, avoid end of life. Now, there's no guarantee for it, of course, right? And Christy didn't say how long her dad has been in ICU for. There's no timelines in the email, but judging from the other previous two examples, I know the timelines there. They were not in a hurry to wean patients off the ventilator and the breathing tube. They seem to be in a hurry to do a tracheostomy or B, end of life. They seem to be in a hurry to do either of that, right? Now that's a concern. That is a concern. Once again, what's the rush to kill someone in ICU? What's the rush to do a tracheostomy? Now with tracheostomies, there is a 10 to 14 day window where someone, if someone can't come off the ventilator day 10, day 14, a tracheostomy should absolutely be considered. And it's reasonable. However, leading up to day 10 to day 14, all resources need to be mobilized to avoid a tracheostomy and to wean someone off the ventilator and the breathing tube, right? So once again, it also comes back to, where's the hurry to kill someone in ICU? Please explain that to me. Where's the hurry to kill someone in ICU? Where's the urgency? I don't understand it. I do not understand it. Okay, let's move on to the next question. If you have any question, please type your question into the chat pad or connect with me live here on the call. You can click the StreamYard link. That's in the chat pad, and I would love to talk to you. I'll be going for up to an hour, so we're about 42 minutes in. Please ask your questions. Now is your chance. Now is your chance. If not, I will continue with the next question. The next question comes from Jack, who says, "Hi Patrick, I'm from India. My sister suffered a subglottic stenosis. So the doctor has done a tracheostomy about 5 days ago. And the doctor has also told us that she has some brain damage. Can you help me for better treatment?" Right. That's a very difficult situation. I'm so sorry to hear that your sister had a subglottic stenosis, Jack, and that she needed a tracheostomy for that. She probably needed an emergency tracheostomy for that. And maybe as part of that, Jack, she had some brain damage, because maybe she had the subglottic stenosis and maybe then she had lack of oxygen to the brain, right? And that is what might have caused some brain damage. It's hard for me to find out why she's got brain damage, but that could be a possibility there. Now, if she has a tracheostomy and she's got a brain injury, potentially a hypoxic brain injury or an acquired brain injury, and she's got a tracheostomy, my advice here is that you speak to her neurologist as quickly as possible. Find out how severe is the brain damage, what's the outlook, and find out whether there are options for neurological rehabilitation, right? I don't know whether there is or there isn't, but that would be your next step. The good news with a tracheostomy here is that that will buy her time, right? In the meantime, what I would strongly recommend, until you find out, can she go to rehab, where is a better place for her to get rehabilitation or get treatment, they need to maximize her mobilizing, they need to maximize physical therapy, right? They need to maximize all of that, right? Because that will maximize her chances to recover in some way, shape, or form. Also, while you're potentially waiting for rehabilitation, the quicker your sister can come off the ventilator, the better. Let me explain. Let's just say your sister is stuck on a ventilator, can't come off the ventilator, can't come off the tracheostomy. She might find it difficult to find a rehabilitation place, because most rehabilitation places cannot look after ventilation and tracheostomy. There are some, right? There are some. But, focusing on rehabilitation is so much easier if someone doesn't have a ventilator and a tracheostomy. Much easier, right? So, so your goal for your sister must be, in the short term, to get physical therapy, get her mobilized, wean her off the ventilator ideally, and then get on to a neurology rehab, ideally without a ventilator, ideally without a tracheostomy. I don't know whether that's possible or not, because I don't have enough information. I would like to look at medical records. I would like to talk to doctors and nurses directly, and so forth. Okay, so that concludes that email. Miss Sharon S., thank you so much for writing here in the chat pad. Sharon says, my father recently passed away in ICU. He was brought to the emergency due to possible sepsis concerns, hypothermia, hypoxia. He was admitted to the ICU in a critical condition. I'm very sorry to hear that, Sharon. What's your question? What is your question? Do you want to know if he, if there was a chance to save him? Explain to me what's your question in this tragic situation. The more that I understand why he passed, do you have access to the medical records? Have you looked at the death certificate? Is there a death certificate? Have you looked at the medical records? Is there an autopsy? Have you done an autopsy? Right? So Ms. Sharon says, however, he wasn't admitted until after he went into cardiac arrest 4 days later. He wasn't admitted, okay. My father, off of all his medications, I feel they allowed my father to die. Right. I couldn't tell you from here. I would need to look at medical records. Once again, Sharon, when someone is in intensive care critically ill, there are dozens, if not hundreds of things happening simultaneously. And unless you look at it through a professional lens, you know what to look for, you know how to connect the dots. It is speculation. Everything else would be speculation for me from here. I would need to look at medical records, right? And that's the only way I can find out, or me and my team can find out, what happened. What you can do from here, you can provide more information here, of course. You can email the medical records, then we could give you a quote, how much it would cost to review the whole lot. You are saying he was never treated for sepsis. They started to treat him 16 days later after I brought it to their attention. How can I send you medical records? Yeah. So Sharon, you can send medical records to this email here. I'm just typing my email into the chat pad. So you can send the medical records to the email that I'm just sharing here in the chat pad. It's support@intensivecarehotline.com. Can you see that? Pleasure. I'm very sorry to hear that. Very sorry to hear that. But I know we can shed some lights on your that situation. There's no doubt in my mind. It's a shame that we couldn't help you while your dad was in ICU. Maybe we could have saved his life. I'm not sure, but we will find out by looking at the medical records whether they've done all the right things or whether they haven't. Look, your gut instinct is already telling you they haven't, and your gut instinct is already telling you that they haven't done all the right things, and your gut instinct is probably right. And you should follow your gut anyway. That's for anyone on this call, whether you watch it live now or whether you're watching this on replay. Follow your gut. Your gut doesn't lie. Your gut doesn't lie. I had another email this week from Princess, who says, I was being told that my dad may not survive and they wanting to turn the machines off. right? Well, that's something we hear all the time, right? So if you are told that your dad may not survive and they want to turn off the machines, once again, have you done any research? I'm telling you once again that 90% of intensive care patients survive, approximately, right? That's number one. That's 1 in 10 not surviving. That's 9 out of 10 surviving. Now, I'm the first one to say to you as well, even if your dad does survive, it doesn't guarantee quality of life. We don't know what your dad's life might look like in 6 weeks, in 6 months, in 6 years. We don't know, right? But one thing is for sure, if he dies, you do know the outcome. If you give him a chance, you don't know the outcome, right? But you got to give him a chance, unless he has advised you otherwise, right? Once again, is it a real or is it a perceived end-of-life situation that your dad is in? You better find out which one it is. But here's another thing. I give you a very good hint, when you can make a determination. Is it a real end-of-life situation? Is it a perceived end-of-life situation? If your dad stays on life support, on maximum life support, right, which we can help you to determine whether your dad is on maximum life support or medium levels of life support, low levels of life support. If your dad or your family member is on maximum levels of life support, right, and the intensive care team is telling you, well, they'll die, your dad will die anyway in the next 24, 48 hours, well, that's a real end-of-life situation. But once again, how many families are we dealing with on a week-by-week basis where they say, well, we've been told they're not going to survive, and then patients do survive, and every day they survive longer, you have to question the clinical judgment from intensive care teams. Is it all a hoax? Why are they telling you your family member won't survive if they're still alive? That's a sign that your family member is in a perceived end-of-life situation, not in a real end-of-life situation. Right? So, I've got time for one more quick question. Oh, and by the way, before I answer the last question for today, we've done a networking event this week in Brisbane for intensive care at home, and I've put a video on the live stream. If you're interested in, the speakers on our Brisbane networking event for intensive care at home, there's a video on my YouTube channel. Right. So Miss Sharon says, my dad was on 30% and PEEP without any inotropic support after cardiac arrest. My father was brought back after being flatlined after 10 minutes and with a PEEP of 4. Okay. Now, Sharon, I argue that he would have had some inotropes during the cardiac arrest. That's usually part of the algorithm. But it might have been only for short periods. Right. Why would they take him all medications? I don't know. Sharon, which country are you in? Are you in the US? Which country are you in? Would be curious to know which country you're in. Are you in the US, Canada? Are you in the United States? The reason I'm asking that is they can't really take his medications away to keep him alive without your consent. That's assuming you are the power of attorney, right? So that's why I'm asking. There are some jurisdictions, especially in the UK, where the hospitals nowadays can do whatever they want, but not in the US. And if anything, I do not want to get political here, but I do believe patients' rights will be strengthened under Trump administration. I would hope so, and I would think so. What state are you in? What state are you in, Sharon? What state are you in? Which state in the US? I can't see it. I can see that you're in the United States. I can see that. But which state in the United States? In Tennessee. Okay. Okay. So we have, as part of what we do for our clients, we have done the research in every single state in the United States, but also in other countries, about patient rights. I don't have it off the top of my head, but I know we've got a section, in our documents where I know we've got patients' rights for Tennessee as well. 99%, I'm 99% certain, Sharon, that they can't take the medications away without your consent. I argue that's a crime, right? There's really no state in the United States where the hospitals can just do whatever they want, especially when it comes to end of life. Anyway, I am going to wrap this up for today. First of all, thank you for staying around. Thank you for attending. Subscribe to my YouTube channel. Click the like button. Click the notification bell so you get notifications. Share the video with your friends and families so we can help as many families in intensive care as possible. And comment below. Right, it's good for the algorithm. Yes, Sharon, get the medical records, send them to me to support@intensivcarehotline.com, and then I can advise of the next steps. We have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivcarehotline.com, or if you click on the membership link, or if you go to intensivcaresupport.org directly. I would welcome you there in our membership. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I do talk to doctors and nurses directly. I talk to you and your families directly. I handhold you through this once-in-a-lifetime process and situation that you can't afford to get wrong. We do medical record reviews in real time for a second opinion. We do medical record reviews after intensive care if you have unanswered questions, if you need closure, if you are suspecting medical negligence. With intensive care at home, we're currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are providing level 2, level 3 NDIS support coordination. We're also providing TAC case management in Victoria, WorkSafe case management in Victoria. If you're an NDIS support coordinator watching this and you need nursing care for your participants, or if you need a nursing assessment for your participants, that's what we do as well here at intensivcareathome.com. With Intensive Care at Home, we have current jobs for critical care nurses in Melbourne, Sydney, Brisbane, and in country Victoria. If you're an intensive care specialist, we are currently expanding our medical team, and we can also help you free up your ICU beds. Same in ED, we can help you free up some ED beds. If you're a hospital executive watching this and you have bed blocks, please reach out to us. Lastly, if you're in the US or in the UK for intensive care at home, please reach out to us. We can help you there privately. Thank you so much for watching. I'll see you again next week on another YouTube live stream, same time next week. And please look out for my videos that are coming during the week. Thank you so much for watching. Thank you for your support. Take care. This is Patrick Hutzel from intensivcareathome.com and intensivcarehotline.com. Take care, and I'll see you in the next video. Take care.